So I was going to go through the first few slides. This is Johan's case presentation. We'll do it second to sort of give a bit more of a logical evolution to this. Bottom line, I think with the discussion we had earlier that had pretty relevant questions in terms of what team members should be involved, what is the role of every single one of them. I think the most important concept we have to realize is that a lot of these patients always either in the weekend, in the evening, in some afternoon of a long weekend, it's complex cases where being alone, stuck, trying to decide what to do with your own personal experience that may be limited, might be quite anxiety provoking, and it's always good to have other members of the team with different specialties to either back you up with a certain decision plan or someone who might have more experience in data to guide you in a more specific direction. So no specific relevant disclosures for this that I'll talk about that are outside of regular indications. So most important thing is to discuss the multidisciplinary approach to assessing and managing complex cases. An illustration through 4 different cases, how a heart team sort of might approach them. I have sort of 2 theoretical cases, which is kind of prototypical cases and how a heart team might approach. One longer case that I have, and then Johan's going to present a case as well to sort of discuss similar aspects. So the heart team sort of has different types of evolution based on how it was developed in different centers. Some centers started sort of a heart team concept by discussing sort of complex coronary or valvular heart disease in the cath lab or a patient that presents in the CCU, where the interventional cardiologist and surgeon get to discuss, what kind of revascularization techniques, be it surgical, percutaneous, or hybrid approaches. The TAVR or aortic valve disease clinics that we have as well have sort of a hybrid or heart team approach for similar discussions in terms of be it surgical and or percutaneous approaches. A popular concept that's been initially pioneered in large part at the Mass General, that's been sort of marketed and distributed throughout the country, of a pulmonary embolism team, which I have a few slides to discuss about that, and it sort of illustrates how sort of a multidisciplinary team can have an excellent standardized approach to the management of a whole spectrum of cases with a particular disease process. ECPR with our ECMO team that we can discuss and we talked about earlier here at the Montreal Heart Institute, as well as a shock team concept that I think is evolving, in large part because, as we discussed, there are a lot of patients that we could or should be supporting with percutaneous and or surgical mechanical support. But I think, as Chris was mentioning, we often get to these patients too late. And the concept of having a rapid response team, be it a shock team or a code shock team, is really just sort of sensitize the physicians that there's immediate backup and it's better to call for them earlier than later, so that at least the management, diagnosis, investigations, and earlier treatment can be done. So I think the concept of a certain mobile team or rapid response team should gain more in popularity, as we'll see. So the classical sort of heart team approach, there are different types of members depending on what type of patient population, what type of subgroup of heart team your hospital is dealing with. Typically in our center, be it acute shock or cardiac arrest team, there'd be a cardiologist, typically of a heart failure variety, an interventional cardiologist, cardiac surgeon, critical care medicine physician, and again, not to forget the perfusionist and other allied healthcare team members that are part of this team. And a lot of the discussions in certain teams was to sort of standardize the approach. So there's a good paper trail, as well as prospective data gathering for a lot of the cases that the heart team gets to decide upon. So you don't just have 5 different notes from 5 different specialists to sort of say, 5 different things. There's a standardized sheet that some patients some centers would use, for example, for revascularization and or valve disease, where bottom line there's an etiology of the cardiac disease, different sort of mortality scores that sort of guide or justify, be it a percutaneous approach, hybrid approach, or surgical approach, as well as sort of a bottom line consensus decision by the group. And that's in large part to sort of make sure that you have a standardized approach and an ability to have a paper trail to deal with sort of quality control issues later on as you review the performance of the team. So the problem with a lot of these complex cases that often, the best treatment is kind of unknown. Fine if you have a pulmonary embolism or acute MI, I think we have fairly good data on what to do, how to do it, and when to do it. But as the patient's kind of slipping and sliding or having bouts of VT or intermittent cardiac arrest or has a PE with a stroke, potentially bleeding at the same time, there's really no known best treatment, and none of these patients are typically in any of the studies or guidelines. So you kind of have to use more of the art of medicine than anything else. And there's no standard approach. So I think it's better to sort of have a collaborative approach with a multidisciplinary team to sort of decide fairly urgently what is the best approach. And as well, the most importantly, is to sort of have a plan B and a plan C. So I think if everybody decides to deal with, a percutaneous approach and there's a major complication or it doesn't go as expected, right away, the surgeon, the critical care medicine physician are already aware of the case, and there's a fairly natural evolution to sort of move on to the next steps, as opposed to, you try doing something in the cath lab, it doesn't work out, there's a catastrophe, you quickly call the surgeon, and he's kind of frustrated that he wasn't advised earlier. So I think the early upfront multidisciplinary team is really there sort of anticipatory of any potential bad outcomes or complications. Now, if it goes well, fine with a simple approach, but I think if there are complications, then at least you have all the other people involved that can help you with what's going on. So the functionality of a heart team, kind of in large part modeled, if we look at sort of a cardiac arrest or shock team, largely modeled in sort of a rapid response team concept that's been developed by critical care medicine physicians, where within a certain set of fixed parameters, rapid contact of one team member with diffusion of the information and contact of other team members, you can have fairly rapid mobilization of various experts relating to that problem. All of them together are able to sort of evaluate the full range of treatment options. And if it's plan A that goes well and that's what the patient needs, then that's fine. But if plan C or plan D are necessary because the patient's complex, then at least you have the experts already on hand to decide where to go with that. Coordinating care among the different services, I think it's already, if everybody's aware and the patient can jump directly from the cath lab to the OR, cath lab to the ICU, at least the people are aware the patient's currently active and has to go in that direction, as opposed to trying to make phone calls at the last minute and surprise people that are potentially already at home. Develop protocols and sort of discuss the full range of therapies, and sort of obviously prospectively collect data to be able to sort of look at outcomes and sort of improve your response times and management of these complex cases. So the pulmonary embolism teams have been sort of gaining popularity. Kind of convenient for them, it's typically sort of, one disease process with a spectrum of presentations, as opposed to what we have to deal with in cardiology, which is a spectrum of diseases with a spectrum of presentations. So it was fairly easier for them to refine exactly an approach where you have an initial pathological event, be it a pulmonary embolism, could be anywhere, presentation in the ward, in the ICU, or in the emergency room. There's activation of the team within certain predefined criteria. There's initial triage person, they'll sort of decide whether or not it's an appropriate call, and then he will be the one who will contact all the other members of the team, which can be included here. And then obviously options and recommendations can be done in the action, and then sort of feedback based on how the patient evolves. So the algorithm used in the Mass General is the following, where they have, patient can enter from anywhere, be it a peripheral hospital or internally. Certain basic demographic and biochemical data can be done, assess the level of risk, and then you activate the multidisciplinary team. And then this team already have pretty much access to all the options available, as opposed to sort of a series of consults where you have to reinvent the story and the wheel every single time you call the next specialist. At least at this point, you have all the cards on the table. And if the patient deals well with just anticoagulation, that's fine. But if the patient has to go for ECMO right away, that option is already available up front. And part of the prospective data collection kind of shows exactly what the bottom line approach is. So if they looked at all their cases, they have demographics, male, female, the age range, medium age range, survival to discharge, and the approaches of what was the final decision and the plan that was ended up being successful with that patient. They realized that anticoagulation only was the majority of cases, be close to 2/3 of cases. But at least, the patient who, let's say, would fail anticoagulation, or all of a sudden would start to bleed massively, right away, those patients can be routed to an ECMO or either IV support or percutaneous radiology mechanism that's already aware of the patient. And they have specific criteria, just as we sort of discussed our own criteria for the eCPR or ECMO But I think as we have to discuss more and more and to sensitize people across the board of patients actually seeing these patients up front, is really sort of the door to goal time, because I think for STEMIs, for strokes, for trauma, I think we know that clearly a rapid response and rapid diagnosis and treatment initiation is what makes biological sense and what makes a difference in the outcome. And I think within their algorithm, they were clearly able to add a time frame in which there's a certain response and goal to their initial therapy, and that's clearly critical in the survival and better outcomes of their patient. And I think so far in cardiogenic shock, which is again kind of frustrating in advanced heart failure as well, where, as people mentioned, you get to the patient fairly late as they're already crashing or already arresting, as opposed to having seen them 4, 5, 10, 15, 24 hours earlier, where the patient is already showing signs of deterioration. The heart team concept, to sort of break the concept of working in silos, where the interventional cardiologist works with his skill set and the cardiac surgeon works with his skill set and his knowledge and risk factors, is really to sort of be able to combine the knowledge and just have a better discussion of sort of what is in the best benefit for the patient in terms of risk-benefit ratio, assessment of access, different types of imaging and complication management and so on, and post-operative care. In the heart team management, cardiovascular care, there are more and more articles being published these days. So I think the framework is there. I think we have to sort of try to adopt these and adapt them to our own hospital centers based on what kind of team you want. But bottom line, we're going to go to the cases relating to how this concept of heart team can sort of be appropriate to our patients. So our ECMO team for the ECPR that was developed has these members on the panel. It was a surgery-driven program initially because access, as we mentioned, was done by the surgical team, and the patient does go to the surgical ICU. So it was a surgically initiated program. Obviously, all the other intervention people involved are there to sort of take care of the patient up front, in the middle, and once they're being weaned from ECMO, and where do they go afterwards, so long as you have a plan B and a plan C of as they're being weaned off ECMO, and then you have to deal with the heart failure patient afterwards and as post-discharge. Our ECMO criteria, as you saw them earlier on, I noticed in the previous presentations, try to be somewhat conservative to have initially good results, to sort of get the team to work properly and have better outcomes. To sort of help the administration understand that this is a concept that does work with pretty good results. And secondly, you sort of don't want to discourage the whole team by having a series of bad outcomes that sort of de-recruit interest in participation of this team. And a lot of these are sort of evidence-based or experience-based from other centers that do a lot of ECMO and cardiac arrest, and criteria for age and other biochemical and lactate parameters is really to sort of deal with the lower risk patient who does have some survivability on ECMO. So the code ECMO has the following team, as we mentioned earlier. So case one, kind of a theoretical case that you might see from time to time. Patient who's 56 years old, has fairly traditional coronary vascular disease risk factors on fairly basic medical therapy, has a sudden cardiac arrest or syncope at home, witnessed collapse by his wife, who's able to call 911 fairly immediately. She's instructed to start CPR, chest compressions. Initially, the ambulance arrives fairly rapidly, and one shock is administered with fairly rapid return to spontaneous circulation by the AED. His ECG, initially done by EMS, that's faxed over to the interventional cardiologist, shows that fairly typical of an acute current of injury in the anterior territory, which is the most likely explanation for his cardiac arrest. And the coronary angiogram at that point in the cath lab shows the following pathological lesion and successful revascularization. However, we know that a lot of these patients, potentially up to 1/3 of these patients, if they're not in shock already, can develop shock within 4 to 6 hours after percutaneous intervention. So that's why there's a fairly high degree of suspicion that you should have, that you should follow this patient fairly closely because he might still go into shock if not already, or have another otherwise mechanical complication. But at this point, already in the cath lab, we find that he's persistently hypotensive. So one negative prognostic indicator of pressure is less than 90. And often you'll have this patient already in 1 or 2 or 3 vasopressors and they're still hypotensive. kind of showing that it's not a systemic vascular resistance problem. It's probably more of a cardiac output problem. Tachycardia, which is sort of an appropriate response to poor LVEF, and a lactic acidosis, which is in part related to the cardiac arrest, failure to clear his lactate, and potentially ongoing shock. And then obviously on the table, he seems to have still a fairly irritable ventricle, in part because of the initial injury and potentially from reperfusion injury that's to be ongoing at this point once he's revascularized, requiring already several shocks. So fairly high-risk profile patient with these three indicators that he's at least currently still in shock and at risk of potentially still deteriorating with his recurrent arrhythmic events. So kind of the point where you sort of call the ECMO team or the code team to sort of discuss what are the potential options for this patient at this time. In terms of what was decided for this prototypical case is, an ECMO was decided based on his profile, with the thoughts that most likely he would either stay in shock, at least for the next number of hours, which would put the rest of his organs at risk and obviously increase his mortality to discharge, as well as potentially ongoing neurological injury. It was deemed by the team that the response was fairly rapid in terms of neurological criteria and early reperfusion. So there's a fairly good chance that ECMO could be a good bridge to good recovery, as it was a witnessed arrest, immediate CPR, fairly early return to spontaneous circulation, and fairly early successful reperfusion. So these would be all good prognostic reasons as per our criteria in the ECMO protocol to sort of go with fairly rapid, aggressive hemodynamic support.
Mark, before you go to the second case, let's discuss maybe the first case. So I guess interventional cardiologist, surgeon, intensivist. So again, open rapidly the LAD, rapid recovery. Maybe I missed it. How come he developed shock? I mean, that's kind of a... Was he already had an MI before? Maybe I missed something.
Yeah, so on the EKG, I think I could note the presence of Q waves and inverted T wave, which suggests it's not super acute, but more like recently acute, so kind of a late presentation, patient asymptomatic, and I think the circulation was left dominant. We only saw one view, but so was there any mechanical complication that should be
No, there was
out?
not. But I think that's kind of the problem we have, is that you get this patient, you have no past medical history, there's no previous echoes, no previous angiogram, and he presents on your table already in shock. You revascularize, and there's still ongoing shock. And I think that's the biggest issue with the interventional cardiologist, was they're all alone. Because you're right, they're good questions. Maybe he had a previous inferior MI, and this is obviously a second injury that's going to cause him to have significant LV dysfunction. Maybe there's other past medical history or ongoing symptoms that you don't have access at this point, that he's had chest pain ongoing for the past 12 to 24 hours, and it's potentially a longer standing lesion than just the 1 hour we think he was. So
the other thing that I would worry about is bleeding, because I can't explain why he's so tachycardic still if he's been opened, and and it could be access site bleeding, but I've also seen retroperitoneal hemorrhage happen spontaneously in this kind of situation. So you have to have a low threshold, I think, to think about that as well.
Mm-hmm. And Johan, if you were called to the bedside of the cath lab for this patient, any thoughts or recommendations of best approaches?
Well, depending on when I'm called at the bedside, there's groups that are starting for patients that are deemed higher risk to just do the 2 punctures on the side that would be dedicated for support, and put guide wires on that access site so that we can access for any type of support device that's already agreed on with the interventionalist and the cardiac surgeon, so that we can go forward and do what seems to be the straightforward PCI. But if things decompensate, we can easily, while the patient's not arrested, use the guide wires to put ECMO cannulae in, and then go on and finish the dilatation if it's not finished yet. Of course, if the patient's already arrested, well, we would attempt percutaneous access for ECMO, but we usually quite rapidly transfer to an open strategy to put the cannulae in, because once it's not pulsatile and the blood in the arteries is already blue, well, it's not that easy to confirm while we're doing CPR. We use ultrasound most of the time to do the punctures, but if everything's already set up, it's much easier to start ECMO earlier.
Excellent, good point indeed. If you're undergoing CPR and there's no pulse, then any type of access is a lot more difficult. So in the patient who suspect to deteriorate, early guide wires are probably a good idea.
Outside ECPR, are there instances where you would put the ECMO or the assist device first before reperfusing? Do you foresee any, or you'd go for reperfusion first? I don't know if you have thoughts on it.
So from what I would think, obviously if the patient's obviously in arresting, and I probably would support first to save the brain and the other organs, and then once he's got actual blood pressure and perfusion, then you can spend the time to potentially more safely do the percutaneous intervention. I think a lot of centers are doing that up front.
I think JF would probably agree that when it's an anterior STEMI like that, sometimes they can settle so nicely when you open them that if it's relatively easy, then I would probably go for that first. That being said, if I run into trouble and it's not as acute as it appears, then you may have to shift gears very quickly and put a support device in or some kind of tool.
And I think that's part of the tough call where indeed, we have a lot of patients that were called for that are clearly, have arrested and they're kind of pre-arrest. You open the artery and within 1, 2, 3, 4 hours, they've sorted themselves out. And then the others, there's a subpopulation where they just keep deteriorating in spite of that. So it's tough to decide on the table.
Here probably the emotion kicked in when the patient developed VF. So say there's no VF on that patient and the blood pressure is 75/X. Do you wait an hour? Do you put a balloon pump, keep the patient in the cath lab, repeat lactates in an hour, and then escalate if there's progressing failure? Because I'm not sure I would have put immediately without VTAC or VF arrest an ECMO device or even a PVAD device. So I'm not too sure about how aggressive you need to be early on because, as you mentioned, they resolve nicely in the first time.
It was indeed the ongoing sort of arrests that were sort of precipitating the fact that the patient's still at fairly high risk of deteriorating and losing his pulse and perfusion. So that I think that was the reason why sort of a biventricular total support device was chosen, as opposed to if you just think he's in shock but he's no longer irritable or arrhythmic, then you could put in sort of a tandem or an Appel device. The balloon pump in this situation, once they're already revascularized, I think is probably just a waste of time. I think if you did have a tight left main where you're going to wait for surgery in the next hour or a couple of hours, I think it's totally reasonable to sort of increase coronary perfusion with a balloon pump. But a balloon pump, once they're already open, I think is, he needs more perfusion than just coronary perfusion. He needs total body perfusion because that's what often killed these patients is multi-organ failure. So I probably wouldn't waste time with the balloon pump.
Any comments from the audience? If just take the microphone and don't hesitate.
I was going to say, I'd like to hear, I know my good friend Simon is there. He's nice and comfortable, but I'm going to... So say you're in your hospital where I'm not sure if you do ECMO on a regular basis. How would you manage this case?
Well, actually, 6 months ago, the only thing we have was a balloon pump, and I do agree with Mark that balloon pump is good for coronary, but it's not worth much for perfusion. We did that a lot, but with the recent knowledge that we had, randomized study, we do that mostly to treat the doctor more than the patient. So, and 6 months ago, I would have said, well, we're putting in amine and vasopressor, and we hope for the best. Transfer them if they're a candidate for surgery. But what we do now, we have ECMO now for let's say we had our two first in the same week a month ago. So and we're restricted. We're not. We have a limited amount of ECMO that we're supposed to do in a year, so we'll have to be very strict on the. But this is a young patient, if I remember. It's like 56. Yeah. So I think and he doesn't have many comorbidities. So I think he's the kind of guy that I would maybe not do it right away because indeed some patient We open them up. Those are mostly those very acute, though, which I do agree with Mark on the EKG. Doesn't look like a very acute setting. You might have had 6, 12, or even 18 hours of chest pain or ischemia before coming in. But if after opening it, you keep going down, increasing vasopressor, and I think that this is the kind of patient I would call my ECMO team to evaluate it. So I feel like keeping the patient on the table for an hour, if it's for the access, depending on whether you're always percutaneous or you're mainly surgical with the access. But this is the kind of case after an hour of watchful waiting, if it doesn't go the right way, I feel that ECMO this is the kind of patient that in my very small experience, would probably benefit from that.
And would anybody consider Impella, or maybe not tandem heart because the patient is anticoagulated? I don't think it's time to perform transeptal puncture, but Impella in this patient? Stefan, you have a comment?
I think one of the key concepts is getting as much information as you can. Get an LVEDP, get your echo people there, get your RV image. If the RV is shot, then an Impella is not going to do much. I think the concept of graded support is something that's important. You're putting in a balloon that you lose one large bore access right there.
I think a PA line is very important as well. I know it gets a bad rap in the ICU world, but certainly we use it. I would never go any further with this case without doing that, because I think it provides invaluable information.
So in the cath lab, you do... Perfect, I like to hear that. Yeah,
right
I
there.
agree with you.
Good point. Thank you. Paul, please take the microphone.
So the question was, if the patient's having recurrent ventricular arrhythmias, putting an Impella in that might potentially stimulate more arrhythmias.
Yeah, good point. Yeah, that's right. Okay.
So, a tandem heart, if your center has access to that and you're skilled to put it in a patient who's unstable, transeptal, I think is an excellent choice.
As an interventionist, mind you, it's sort of, and other interventionists can comment to this effect. I mean, doing a transeptal in an anticoagulate with 2B, 3A patient, even, it's 2 o'clock in the morning, calling your colleague to get a transesophageal echo is not ideal to do it safely. I think this is where the ECMO has to come in first, if you're already with an electrical storm on its way.
And frankly, this case is... we reviewed the last 600 cardiogenic shock patients we had in our hospital, and we had still 50% cases that weren't getting out of the hospital. A little better, of course, in younger patients, but of course he might do well after the PCI, and that's great. Hopefully that will solve the whole problem, but the shock being present for a while, which is illustrated by the high lactates, which is not an acute process, probably being relatively proactive, maybe an hour, maybe even up front, will lead to a very short support time if it works. And if it doesn't work, well, you will know while you're already supported and the other organs are not paying the price. So it gets you a nice candidate for a longer-term VAD if the whole ventricle's gone, where otherwise the next morning the patient's not a candidate for anything else in the long term.
So you're taking for the ArtMates of this world?
Well, we're not putting HeartMate or hardware in a patient that's in shock, but on someone who's on ECMO for 6 or 8 or 10 days with no organ failure that's extubated, there's no reason not to go for it. And those patients, the results are not that bad of going to longer-term VAD if you were able to solve the problems of multiple organ dysfunction early on. So yes, it might go the right way, but if it goes the wrong way, we need to have the safety net available so that it doesn't go too deep and that the patient doesn't burn any bridges.
Good points. Stéphane, you have a question, a comment?
Well, because Mark asked me a question, so I'm here to answer. That's the point. I think we're in our center where you're dealing with a shock patient. You obviously, it depends. Are you able first to do what you want to do in the coronaries without support? That's the first question. And sometimes They're a shock patient. They're a shock patient. First, you need to intubate them sometimes. Sometimes they're not close to the tube. You can start, you can do whatever you want. But if you're not able to do what you're gonna do because the patient is too unstable, then usually what we have the most readily available is the balloon pump. So I think most people will put the balloon pump and bridge to an Impella later on. But I think most people will start with this because it's readily available. But it depends if you're dealing with a crash and burn situation. I mean, if you have a patient then it's going down the drain so fast, the Impella is not gonna do anything. You need an ECMO at this point. So I think it sounds a bit like difficult sometimes to make a decision, but in clinic, when you're dealing with those patients, it's not that difficult to know which patient is a balloon pump patient for now, like an Impella patient, or a crash and burn ECMO right now, right? Most of the time, I think you can make that decision quite quick. The problem comes when you've been able to do whatever you wanted, then you're on a balloon pump, and then the patient goes to the CCU, and then it's having this feel of you're not going in the right direction with a balloon pump, and then you should bridge to something more effective like an Impella or a tandem heart. And I would bounce the question back is like, what is your criteria? What is because we have shock patients, we've been managing shock patients. They're typically on multipressors, so they're back there, they're alive, they have open arteries. We don't know yet that they're not peeing because it's only been an hour. And now it's like it's in the middle of the night and then someone wakes up and say, we don't have any urine output. We've been there and this. So when do you decide to increment on the treatment?
I mean, it's interesting because we have specific criteria for someone who's in shock. And yet, if you want to discuss, we still have 50% mortality, which is the same as like 15 years ago. So I think the PA line in high-risk patients, I think is probably crucial to be able to follow the hemodynamics of his patient to say, 1 hour, 2 hours, 4 hours post-revascularization, he still has a low index. He hasn't started to clear his lactates. He hasn't started peeing it because he has a Foley catheter in place. But I think that the upfront instrumentation of a lot of the patients that do end up dying in cardiogenic shock in the CCU hasn't been done. And a lot of these patients, I noticed myself, they get the PA line, they get the ART line and stuff the following morning when the lactates are still 8 and they haven't peed all night and they haven't had a Foley catheter. So I think it's really up to be it an algorithm or a protocol or something that upfront you have criteria in the cath lab to say, I've done my job, everything that I could do percutaneously, this guy could evolve well, or he might start to deteriorate. We have to follow him super closely for the next 4 to 6 hours, because I think most people declare themselves within the first 6 hours. And I think we look at lactate clearance, we look at
a transplant team that it's a mandatory consult for them, and we follow the mixed venous. And if we haven't put a PA line in, they won't let us go more than half an hour without getting one in. Follow mixed venous and lactate, and every hour or so. And if it is trending down, then I would say by 3 hours the trigger is pulled.
Right. And I think we get a lot of pushback sometimes by saying, PA line that's very aggressive and central line, and he's on 2 antiplatelet agents, there's a risk of bleeding. But he's got 50% chance of dying. So I think the risk of putting a PA line, the risk of doing hourly labs for the first 6 hours, I think is a small price to pay to be able to salvage that patient who keeps going into shock, that you might actually be able to put him on early device. Now there was Johan talks about sort of early implementation of total assist with ECMO. And I think there is data out there that shows that if you go partial support up front, and he fails, and he goes into shock or stays in shock, and then you try to upgrade to another device, your mortality is obviously going to be much worse than if you go full support or higher level support up front. Because you don't waste time. By the time you put the balloon pump in, you wait another 2, 3, 4 hours. He's been in shock for 2, 3, 4 hours. Then you try to go for maybe an Impella, but it's not enough. Then you go for ECMO the following morning. The kidneys are cooked. The brain has ischemic injury above his cardiac arrest reperfusion injury. So I think you've lost a lot of points at that point. So I think it's a reasonable process in some patients that whether you can already on the table decide full support upfront ECMO or full support LV support with an Impella 5 or a tandem, I think is the way to go. And if he doesn't need it and gets better by himself, the next morning, the day after, you take it out, which is kind of an expensive decision. But I think that gray zone of who's going to get better or not is really tough to know on the cath lab table for many patients. If you're doing
Great points.
CPR,
Yeah.
I think.
Yeah. Do you have another case for us? I mean, that's great discussion. Thank you very much. And let's continue for the next case.
So the second case is one of a 68-year-old male, so a little bit older, found down at home by someone who lives with him without a pulse. There's already some past medical history that his caretaker knew about, who's followed at the heart failure clinic known for non-ischemic cardiomyopathy for a number of years, with an ejection fraction of about 25%. Morbidly obese, diabetic, and sort of, we were able to find out fairly rapidly he had pulmonary hypertension and chronic renal failure with a creatinine of about 250, which gives about clearance of 20 for this patient. So EMS arrives fairly quickly when the patient was found down. CPR was started and patients intubated. ACLS was started fairly early as soon as our EMS arrived there. The AED did not recommend a shock at that point. Possible rhythm on the monitor by the EMS team suggested either asystole or fine VF. And then by the time the patient arrived at the emergency room, about 15 minutes later, he was still undergoing CPR. The initial ECG done by EMS that was looked at by the emergency doc is something that looks fairly tragic like this. Sort of a unfortunate wide QRS agonal rhythm that can be due to many causes, including sort of long downtime, ischemia, and other electrolyte abnormalities, or just some other catastrophe. So ACLS was continued, and so far, sort of about 36 minutes since EMS found him, and potentially longer until he was discovered. Initial biochemistry in the emergency room during the resuscitation was a lactate of 18, end-tidal CO2 of 14, with ongoing CPR, PCO2 of 88, and potassium of 6.6. So I'll ask the panel again here. So the emerge doc is, says the guy's, 60s. He's arresting. I can't get a pulse back. Call a code ECMO. Johan Lamarche and interventional team shows up. So what would your opinions be at this point based on this profile?
It's very difficult to say no when someone else asks you to help, and that's why we built that algorithm, which can say no instead of you saying no. That's probably one of the cases where I'd say, well, you know what, we don't have, it's outside of our local guidelines. I would probably not go on and put an ECMO in that patient. I think we are bound to poor results in that patient, and we probably would have him for a number of days of undue suffering in the ICU with a uniformly bad outcome.
Chris or Marc?
Yeah, I think that there's so many negative prognostic factors, and your baseline was so poor that the whole undue suffering thing is a huge issue. I mean, the only advantage is giving the family a bit of time to come to terms with the fact that this patient's not going to survive, which obviously isn't necessarily easier, and sometimes it's easier in this situation not to offer it. If you offer it, taking it away is terrible, and I think that that's likely what's going to happen. I don't think that you'd need to take it away. I don't think the patient would survive more than, let's say, 48 hours, but if they did, then you're in that terrible no man's land.
And I think the algorithm you made to kind of help us, not even maybe call you, help us also medico-legally and also with the family, because when you start discussing that, they don't know exactly what to say, their emotion, and the team doesn't know the patient. But this patient has a cardiomyopathy, poor ejection fraction,
renal failure, obesity.
He didn't have a defib, so maybe it was already discussed with the treating physician, and you don't know because the weekend at night, and because he doesn't have a defib, am I correct?
That's right. He didn't
had poor LV, so probably there's been some other criteria, or even the patient himself, maybe he said, you know what, I don't want to have a defib. So if it's not written in the charge from some other hospital, these are things that happen,
Given
And that's the lack of information that causes these cases to be so difficult, because indeed he might have had a DNR already signed. He might have had other a lung mass or other sort of cancer comorbidity that caused the EP team not to put a defibrillator in because of poor prognosis.
I would call the EP doc at 3 in the morning to
fax him the ECG.
bring precision on the need for an ICD.
But I think, I mean, and as tragic and rapid as it is, I think the family would come to terms that, he's passed away after, good resuscitation, as opposed to seeing him on ECMO, and then you have to decide, okay, now he's on ECMO, now how do you turn off the ECMO, or who turns off the ECMO, which might be potentially a lot more. And any other potential option, be it, organ donation or plan B, be it LVAD transplant and all that stuff, I think, clearly we're all agree that there's no good plan B for this patient if he even does survive.
If you were to presume that this is from ischemic origin, would you even bring this patient to the cath lab? And I guess this is open to discussion. Right? So I'm not even sure I would bring this patient to the cath lab.
I mean, unless you can find a fairly normal coronary angiogram from a few years back, and I think there was initial diagnosis of non-ischemic cardiomyopathy. But I mean, diabetic and obese, absolutely he might have had another ischemic event. But then again, potassium was up 6.6. He could have had an arrest on a hyperkalemic event, or the differential diagnosis is fairly broad, and I think that's why if I go to my other slides, I think that's the reason for the algorithm, as we discussed here, based on our team. But I think that's the point of the algorithm, that once you have sort of criteria here, where you have asystole's initial rhythm, quite often you can have an initial process that's going to kill the patient that's non-cardiac. It could have had a massive retroperitoneal bleed or GI bleed or a big stroke or something like that. And these are non-salvageable ECMO patients. So I think that the initial rhythm that points to a purely, potentially reversible cardiac event with a fairly early time frame, I think is the best way to do it. So this patient clearly had, fairly bad prognostic sort of non-indicator indications and sort of some bad contraindication criteria. So indeed, this patient was not offered ECMO for exactly those reasons.
This is a little bit off topic, but I'm always telling the residents to be very careful with the diagnosis of non-ischemic versus ischemic cardiomyopathy. Sometimes it gets lost in the chart and you don't really know what the etiology is, but I can think of at least one case where the patient had truly normal coronaries, but they actually had an atrial embolic event that went down the coronary and caused an anterior STEMI that was purely embolic, and people were saying, oh no, there's no reason to cath them because they're normal coronaries. They just got cathed 2 months ago or something. And in this case, we changed our decision and found a big problem. So
yeah, and similarly, I've seen a few patients in the past couple of years where they had like normal, perfusion MIBs, percentine MIBs, and deemed non-ischemic, and then they have recurrent chest pains, and you do an angiogram, and they have left main disease. So in fact, they are truly ischemic with a false negative nuclear study. So I think an angiogram is, could be reasonable in most patients, just because coronary disease is so prevalent, or embolic events in these high-risk patients are fairly relevant.
But will the angiogram change the prognosis of that specific patient? I'm not sure. Again, Chris, you're leading that section. I mean, we're writing that for the CCS. So again, that's why at some point I said, what are the patients you should not even call the ECMO, not even call the cath lab? So with that case, I'm not sure I would even activate the cath lab. Like
Here's a good, perhaps, Ariel, I see you from Trois-Rivières. You care to comment about this? So, because you're the one calling the team at your center. Ariel Diaz from Trois-Rivières. Sorry for putting you on spot.
I was really thinking about it, and I thought this patient, fast forward a year, and that is going to happen to us in a new cath lab with the team. And I think that the best option, and the only option, is like Stéphane said, the first thing is to, perhaps for us is an intra-aortic balloon pump and wait and see with vasopressors and see what happens. An early intervention, or an early call for surgery, our surgeon colleague for having advice, it wouldn't be an option because we're 90 minutes away from the closest ECMO center, or perhaps a balloon pump and vasopressors and wait to evaluate what's going on the next day. That would be an option. I don't know what you guys think.
Well, I mean, if you're going to put a balloon pump in, might as well do an angiogram if you're already in the cath lab, or if that's...
I'm talking about case one.
Oh, case one. Okay.
No, case two. I would just let him go. Or call